Hello, everyone. Thank you very much for having me. My name is Dharam Khumbani, and I'm an interventional cardiologist at UT Southwestern in Dallas. And I'll be talking to you about patients needing antiplatelet and anticoagulant therapy. So again, I don't have any relevant disclosures. So I'll start with a case just to kind of set the stage for the discussion. You have a 70-year-old male with a history of lung cancer, COPD, CKD, hypertension, chronic AFib, who's on apixaban and an EF of 25%, who comes in with shortness of breath, angina, and has had already 3 episodes for heart failure exacerbation. And then when he undergoes cath, you see he's got some left main disease. He's got a tight LAD, which was positive based on IFR testing, some CERT disease, and then also osteal RCA disease. And so he's turned down for surgery because of high surgical risk. And the plan is for stage PCI. So he undergoes orbital atherectomy. He has a DES placed, IVUS optimized, and it looks good angiographically, with plans for bringing him back for the RCA. So now the question is, he's already on apixaban for this condition. What are you going to do for the antiplatelet anticoagulation plan in this patient? Now, we know that this is a very common scenario, and about 15 to 30% of patients with AFib will eventually need PCI and antiplatelet agents in their lifetime. And at the same time, patients on chronic oral anticoagulation with coronary artery disease are 7 times more likely to need other antiplatelet agents. Now, we know from older studies such as ACTIV-W that aspirin and clopidogrel are not as effective as warfarin for patients with AFib. And then also from the STAR study that aspirin plus ethynopyridine is more effective than warfarin in patients with stents. So really, you have this, 2 competing issues. So you have non-valvular AFib, which is sort of this lower shear stress situation with a high risk of thrombosis, where anticoagulation is superior to antiplatelet therapy. And then you have a PCI where you need antiplatelets, which is a high shear stress thrombosis, which is platelet mediated, for which you need dual antiplatelet therapy. So when you have both conditions, you really need to just stick them on triple therapy. The problem is, even if you add one agent to an oral anticoagulant, you significantly increase the risk of bleeding. And so a single agent added to warfarin increased the risk by 60%, and adding dual antiplatelet therapy increased the risk almost 2 to 3-fold. And it didn't matter whether it was warfarin or, in this case with Relive, whether it was the novel on the dabigatran, that it was still a higher risk. So the first trial to sort of try to look into this was the WOOS trial, which was 573 patients, where they basically randomized patients to drop aspirin and continue on just clopidogrel and warfarin. And interestingly, versus triple therapy. And interestingly, they saw not only was there a reduction in any bleeding, but there was also a reduction in the ischemic endpoint in this. And so this trial kind of really set the stage for subsequent trials. These are all kind of summarized here. So following WOOS was Pioneer AF PCI, which was done with rivaroxaban. Again, the dose was slightly different. Dual PCI done with dabigatran, Augustus with apixaban, and then Entrust AF PCI with edoxaban. And all those trials kind of had a similar construct. You had an oral anticoagulant, you had a P2Y12 inhibitor, and then aspirin was dropped. Now, the design of these studies was a little bit different, though. So remember, there were 2 things that were being tested. So one was warfarin versus a novel oral or a non-vitamin K oral anticoagulant, or a NOAC, versus a triple therapy strategy, which was having 3 agents versus 2. So there were 2 different things. And really, the only trial that has tried to separate these 2 issues is the Augustus trial, which randomized 4,600 patients like this. And it was a 2x2 factorial design. So on the one side, they got randomized to apixaban full dose for AFib 5 BID versus a vitamin K antagonist. And then the other factorial randomization was aspirin versus placebo. And what they showed is that the highest risk of bleeding was clearly triple therapy with warfarin. And so vitamin K antagonist plus aspirin had the highest risk of bleeding. And that the best sort of profile was for apixaban plus a P2Y12 inhibitor. So again, it kind of shows both strategies compared side by side. And having apixaban as your choice of an oral anticoagulant. And as far as dual versus triple, you choose the dual antithrombotic regimen. So when you looked at sort of the ischemic endpoints, as I mentioned, there was a reduction. There were no different. Bleeding was clearly lower with apixaban, but also some of the ischemic endpoints tended to be lower. Aspirin versus placebo, sort of there was really no difference between the two. Now you can put this in a meta-analysis, and this was done by Renato Lopez and colleagues. And not surprisingly, they put all these trials together. Not surprisingly, having a NOAC plus a P2Y12 inhibitor had the lowest risk as far as STEMI major bleeding was concerned. And then also looking at all the different bleeding endpoints, including intracranial hemorrhage, that came out superior, but there was no difference in primary MACE. So then do you basically drop aspirin completely? I think it sort of depends. If you look in the trials that I mentioned, there has been sort of a variable use of aspirin. Some of them only use it to hospital discharge. In Augustus, you actually were using it for 7 days. There's also a very interesting sub-analysis from Augustus that may help decide how long you may need to keep them on aspirin in addition to NOAC plus a P2Y12 inhibitor. And that's almost typically clopidogrel, by the way. So in this sub-analysis, they looked at randomization to 30 days, so the first 30 days. So again, bleeding was clearly higher when you put patients on aspirin, but there was a lower risk in the ischemic endpoint of CV death, MI, stroke, or stent thrombosis. And then when you look from 30 days to 6 months, you saw all the bleeding harm, but you did not see that benefit. So this does suggest that perhaps if you have certain high-risk patients who have a low enough bleeding risk profile, then for the first 30 days, you could consider putting these patients on triple therapy with aspirin. Now, this is sort of in the acute setting. What do you do long-term? So this is the other side of the spectrum. Once you finish the PCI, they've completed a year of antiplatelet therapy. What do you do at that point? Is there any data on de-escalating antiplatelet therapy for that? And there is. These are data from the FIRE study, which was done in Japan. And interestingly, they took patients who are stable, so they did not have active ongoing ischemia, no stent thrombosis before, and they were randomized to rivaroxaban monotherapy. This is lower dose than usual, 10 or 15 milligrams per day, versus rivaroxaban plus an antiplatelet, could be aspirin, could be clopidogrel, or sort of in few people, prasugrel. And again, not surprisingly, the combination therapy had a higher risk of bleeding. So when you put patients on a NOAC plus an antiplatelet agent, you had a higher risk of bleeding after 1 year compared with patients who were just on a NOAC monotherapy. And interestingly, the primary efficacy endpoint also trended to be in the right direction, although this did not meet criteria for superiority because this was not pre-specified. So all of these things, it's a very challenging field. I chaired the document that the American College of Cardiology put together on this particular scenario, which is what do you do when patients need antithrombotic and antiplatelet agents? And then these are some of the figures on that. So the typical scenario is you have somebody with AFib who's on lifelong oral anticoagulation who needs PCI. And so then the first thing is, what do you do? So if it's PCI for stable ischemic heart disease, you would do a P2Y12. Again, clopidogrel is sort of the drug of choice pretty much for most patients for 6 months. You would continue oral anticoagulant sort of indefinitely on the other side. And then between 6 and 12 months, it's sort of really unclear whether, what the right treatment is. There are no data for dropping antiplatelet agents at 6 months. I want to be very clear about that. So you still have 6 to 12 months. A FIRE was beyond 1 year. So between 6 and 12 months, you still ideally would cover them with some antiplatelet agent, either aspirin or clopidogrel. If you are undergoing PCI for an ACS, then it's easy because you just do clopidogrel for 12 months, and then you continue oral anticoagulant uninterrupted on the other side. And then what about the converse? You have somebody who's on an antiplatelet, but now has a new diagnosis of AFib. So again, it sort of depends on the reason why they're on an antiplatelet. For a lot of the things, you can probably stop it. So if they're on it for primary prevention, if they've had a PCI a long time ago, PAD or cerebrovascular disease, you can pretty much stop the antiplatelet and switch them to an oral anticoagulant alone. But certainly the timing, so if you're within 12 months, let's say of ACS PCI, then you would sort of do the same. You would stop aspirin, continue clopidogrel, finish out 12 months of P2 white well inhibitor use, and then just switch over to monotherapy with oral anticoagulant alone. So the need for both of these agents is a common clinical dilemma. NOACs are better than VKA, but the dosing is important. I mentioned that some of the studies like Pioneer use different dosing for rivaroxaban. So that is very important to understand that. Double therapy in general always has less bleeding long-term, and the efficacy appears to be preserved. Clopidogrel is pretty much the P2 white well inhibitor of choice. And then if there's high stent thrombosis risk and a low enough bleeding risk, you could consider triple therapy for a month. And then based on the fire, you could consider dropping the antiplatelet after a year if you're going to continue them on lifelong oral anticoagulation. Thank you.